insulin to patient with HbA1c more than 10. And it was collected by more than 525 healthcare professionals. And how to handle them? Again, the three issues are there: the knowledge, the attitude, and the practice. So the education and the skill development. So we should know why education is important, and that is very important. And KFP questionnaire tool may be utilized to find out the root cause behind psychological insulin resistance in physicians, which can be tackled accordingly. We concluded a role played during the workshop to address the PIR in patients as well as in physician, and we found that these are the effective ways of communicating correct attitudes and practices. And this is the whole team who helped in doing and working out the things. And finally, two lines I think I'll say that I think we should strongly motivate physicians that education is very, very, very important. And number two, we should have some independent access to the patient. That patient should be motivated enough to say, sir, please educate me. Because patients are more interested in digital management rather than education. And we are also.
Thank you very much.
Thank you, sir. Thank you.
It was a wonderful workshop with the KP survey and answering each point discussed in the KP survey. Thank you, Rishi. We pass into the next presentation by Dr. Debashis Basu on the insulin for life and insulin for every Indian citizen.
Hello? Yeah, tell me. ஒரு ECG முதல்ல எடுத்துருங்க.
Hello.
இல்ல ECG முதல்ல எடுங்க.
Just.
இல்ல ECG பார்க்காம எப்படிமா சுவிட்ச் ஸ்பீட் மானிட்டர் பண்ணி நீங்களே சொல்லுங்க. ECG எடுக்க சொல்லுங்க யாராவது வந்து. சரி.
Yeah, I can see that. I'll just.
ஆமா. இன்க்ரீஸ் பண்ணாதீங்க. ஈகோஸ்பிரின் 75 போடுங்க. அட்டரோஸ்டாட்டினை வந்து இன்க்ரீஸ் பண்ணுங்க. ஈகோஸ்பிரின் 10 வராது. ஈகோஸ்பிரின் AV 10 இருக்கும். AV 10 வரும். ஈகோஸ்பிரின்னா அது 75 150 தான் வருது. ஈகோஸ்பிரின் AV ஈகோஸ்பிரின் கோல்ட்.
Thank you. Sir, my teacher, my revered teacher, my not only revered teacher, my examiner in MD, Professor Ashok Das, and of course the entire Novo Nordisk team to get me on the National Insulin Summit, and this is for the first time, and I'm extremely happy. I must be grateful to all of you. It was a workshop basically meant to address the problem of the lack of insulinization proper in this country. So this workshop was entitled as Insulin for All, and we had the following people on board. Next slide. We had Professor K.M. Prasanna Kumar, who was the chairperson, and our sir as a coordinator. Facilitator was Dr. Ansali, and of course the five of us were on the panel talking on the different subjects that were given to us. So can we get to the next slide, please? Next slide. And we have those lot of participants. The August participants were there. I can't see this slide. Are you rolling them? No problem. The objectives of the workshop that we had was, to prepare a framework for the next slide for the simple guideline. That's a kind of a guidance booklet that we want to project to this country or the healthcare professionals that are there in the country who are still not, as we came from, Rishi Shukla sir's workshop summary, he was there for the psychological insulin resistance, the PIR. We are now into that stage where it's a physician's initiation reluctance. The physicians they know about the insulin, they know about the holy grail called insulin, but they are not somewhere confident about the usage of it. So we had this workshop where we had laid out some guidelines as to how we can do it. We explored the possibilities, and this is the framework that we had designed. The next slide. That we wanted to build up a kind of this capacity and confidence in the physicians' minds with regards to the usage of insulin therapy in their routine clinical practice, to facilitate timely initiation of insulin, to control the burden of uncontrolled diabetes that we keep talking about. Though we write insulin, yet we don't get the good results from the insulinization. So where are the defects? How can we do the self-monitoring of blood glucose to see the time in range, and of course do all the necessary things that one has to adhere to, in terms of lifestyle, etc. And in different situations, we talked about whether he's an elderly, whether he has some liver disease, he has some kidney problems. So how we can actually tweak and titrate insulin in those settings. And this booklet will actually serve as a ready reckoner for the best utilization of insulins. Can I have the next slide? That's all in the next slide as the objectives of the workshop. So in various scenarios, so we covered from from a normal looking diabetes person to a very serious comorbid case, to a person who has all the other associated complications, giving rise to different kind of setting scenarios like pregnancy, etc. So we talked in details about that. So next slide. The next slide was to introduce insulin, and we had to know it as a superhero was Dr. Hitesh Punyani, who was talking on that. So what he said summarily was, he said that we have short-acting insulin, which is the regular human insulin, and then we have the analogs. We have the rapid-acting insulin analogs, which controls the postprandial hyperglycemia. Obviously much more physiological. So, and we now have the FIAS, which is almost twofold higher with the insulin exposure compared to the insulin aspart, the Novolog or the Novo Rapid. And then we talked about the intermediate and the long-acting insulin, which is Glargine U100, U300, Detamid, NPH, and of course Degludec. So the long-acting and the ultra-long-acting, we talked about their variability, the intrapatient variability. We talked about the duration of action and all the good things associated. And finally, we talked at length about the premix analogs, which actually takes bulk of the share of the Indian usage of among the population of diabetes, is the premix. Well, whether it's a it's a kind of a biphasic insulin, Lispro, aspart, or a biphasic human insulin, or it's a IDEG asp, which is the new Degludec and aspartic, or the Rhizodec. So we talked about how to use those injections, where to use them, what is the basic advantage of the lower number of pricks, and if you can tweak your lifestyle well, then they're set into this kind of an Indian profile the best way. We talked about the safety and flexibility.
Devashish, you have last minute to wind up.
Yes, sir. So basically, this is all about timely initiation, proper dosing, insulin delivery devices, the correct techniques that we talked about, and we talked about also preventing hypoglycemia, looking at the weight gain, those parts, and the intensification part was well dealt with. That we start well, but we need to know where and how fast we can do it. So that's something that we need to learn, that we must be the change that we wish to see in this world. And therefore, it is not only that you have the willingness to listen and act on the inspiration that the doctor gives. That is, what is imperative is the willingness to change your own life as you desire. So keep on with that psychological support with the patient, and be the friend in need when it is insulin, how to take the challenges when you are in a hospital, in a critical care setting, in your home, with the different complications that you have. And if you're a pregnant woman, then what are the things and challenges that you need to do. So, and finally, we had all these special scenarios which were very clearly dealt with by Dr. Deep Dutta and Dr. Samir Agarwal. And finally, my last pledge is that we have to think big and start small and move fast. And that's Mayo Clinic Center for Innovation that keeps us telling us that we need to actually sit down with this book and make sure that this book actually gives us a very clear understanding that insulin is the holy grail. And if you know the art of prescribing it well, then you can actually change the world, if not my own country. So thank you, sir, for giving
me. Thank you very, very. As a booklet, the Devashish, remember, it ultimately we thought we must have a complete book on the insulin for all. Thank you. Thank you, dear friends. We are passing on to the event of the day, and that's our dear friend, Dr. Professor Nalini Shah, very dear to us, going to deliver the Lifetime Achievement Award oration. Nalini, you are the star of the day. Your oration is the event of the day. I'll request Kunal for the facilitating the citation and your oration. Nalini, please.
Let us now pass on to the very important program of today, the Lifetime Achievement Award Oration 2020. Having completed medical training in pediatrics from Sar JJ Group of Hospitals, Dr. Nalini has been associated with India's prestigious institutes including CMC Vellore and KEM Mumbai. She took over the reins as the professor and head of the Department of Endocrinology at KM in 2004, and she has been instrumental in transforming the institute into an extraordinary pediatric endocrinology center globally. Today, it caters both to the pediatric and the adult endocrinology cases. Dr. Nalini's zeal for quality research led to the establishment of a molecular endocrinology laboratory in 2007. The monumental original research work orchestrated by Dr. Nalini gave the department a global recognition when it was chosen as the first international center by the US Endocrine Society for Ambassador Exchange Program in 2013. During her first career spanning over 4 decades, Dr. Nalini has been an academician par excellence. She has worked in a wide array of endocrinology conditions including diabetes mellitus, growth disorders, postmenopausal osteoporosis, pheochromocytoma, etc. Besides ensuring state-of-the-art, very important care for her patients, her contribution to medical education and postgraduate training is of great mention. She has been actively involved in the several national and international research programs like Genesis study, has been the principal investigator numerous clinical trials, and also she is on the task force for the ICMR in the diabetes in the young registry. She has over 190 publications in various peer-reviewed national and international journals. Dear friends, the topic for today's Lifetime Achievement Award oration by Dr. Nalini Shah is very exciting. The art and science of medicine, the journey of joy. Nalini, all is yours.
Yes, please. Good morning, ladies and gentlemen. It's indeed with a matter of great pride and privilege that I accept this Lifetime Achievement Award from none other than a very senior and an honorable colleague, Dr. A.K. Das. Professor Das, this is a moment of pride for me, a moment that I will cherish throughout my life. And thank you so very much for this magnanimous gesture on your part. I'm sure you had a very difficult choice. You had umpteen number of colleagues to choose from, and to be bestowed this honor is a rare privilege which I shall always remember. I was just debating with myself to ask myself what should be the topic of this lifetime achievement oration. And I realized that all my published work is in public domain, and it's something which is most accessible for everybody. And I'd rather put together the essence and the learning lessons that I have gone through as I learned the art and science of medicine, to use it to perfection, to use it for patient care being raised to another level, and to raise the bar of our own scientific fraternity and our own postgraduate teaching. And that's what I have done in this particular oration. And I'd love to share this journey of joy with all of you. When we begin our journey as medical student, I think we have set our path in our mind long before we have joined. And going through this sort of curriculum of MBBS followed by MD, followed by subspecialty is something that we all sort of yearn for and look forward to. And as we begin this very formative foundation years of MBBS and go through those basic subjects, what a joy it was to learn, and what a learning fundamentals. Even today, when I need to kind of go back to learn some subject, it is always anatomy, embryology, and physiology, followed by what I am trying to grasp as of today's innovation or today's medical subject under education. And that building foundation is so supreme. It stands tall for all our learning throughout our lives. The very impressionable mind then encounters suddenly a complete change of scenario, and we come up with this clinical medicine related exposure, where for the first time we are accountable for all our actions and all our decisions. And for the first time also we face in our life lot of limitations which exist in our patient management. But what you learn through all these difficulties is a mindset. It's a mindset which tells you that you cannot be limited by any of these limitations, and unlimiting these limitations in your mind is the first key to learning further on in your life. And that's what you sort of truly learn in this formative clinical years. Begins the training of our favorite subject, the subspecialty of endocrinology, which I continue to enjoy, which has given me my true identity and the true joy in my life. And what a wonderful year of training it has been. And I think, in essence, the training continues even today. The furthering of this training by going abroad and sort of increasing the depth of knowledge and bringing that added dimension was always a dream, and spending those 2 years in UK was the proof of that. And what we brought back with us is self-confidence and the reliance in our own system that we can do very, very well even within our existing conditions. Then began the journey of joy, the journey of joining Department of Endocrinology at the end of subspecialty training in endocrinology. And of course, as you go through all these pyramids and all these sort of escalating responsibilities of becoming from lecturer to professor and head of the department, and now, of course, emeritus professor, you realize certain fundamental things in your life. The journey of joy was sort of bestowed with these milestones, which is what I'd like to share with you. And I call them my learning of 10 commandments. And here it goes. The first part of the learning is that education is a continuous process. No amount of degrees put a stop to it. No amount of positions or seniority ever puts a stop to it. And learning is a lifetime commitment and a lifetime of joy, which continues throughout for all of us, the clinicians who want to make some difference to our patient and who always want to raise bar of our patients' management to precision and, of course, a personalized care that we want to hold on to these patients. Patients are our best teachers. No amount of learning from books or journals or periodicals can bring the clarity of the purpose and the depth of learning what patients teach you. The sheer spectrum of learning that these patients come up with and the sheer spectrum that you see in teaching departments is what brings the joy of learning the degree or the subject to its entirety. And this learning is further clarified as it gets questioned repeatedly by your brilliant, outstanding postgraduates. And I think my biggest joy and my biggest blessing of the life has been my very learned postgraduate students who have actually taught me endocrinology, and I would be eternally grateful to these bright young minds who decided to join our department and get trained in our department. Our seniors like Dr. Bhandarkar, Nishit, Manoj, Subodh, Sonu were so instrumental in teaching me the fundamentals and hand-holding me in my training period. But it's my postgraduates who continue to be the beacon of light, who always paved way for learning something new and who always paved way for increasing the depth and the dimensions of the subject, to whom I shall be eternally grateful. And it's the passion. It's a passion for learning. It's a passion for achieving what you want to set out to do, which makes all the difference. And no limitations can exist when you feel passionate about something. Multiple faculties internationally who come from international shores, who come to India, are always more than willing to come over to your department and to teach you and to share with you all the learnings that they have gone through. And I'm sure we had huge amount to showcase as well and to show them to kind of feel confident and reiterate in our own learning as well. Here is a professor from Michigan University who chose to spend with us 2 weeks. And that was such a joyride and such a great piece of learning that we went through. And if not the physical presence, the webinar that we kind of have been holding with all the learned faculties for the last 3 to 4 years. And here is an example of learning from none other than Dr. Kustin, all the realms and the nuances of gestational diabetes mellitus, where the time is never a limitation, and the Q&A and having this faculty on a one-to-one, despite the geographical limitations and despite the time zone differences, the learning can be such a joyride, and without any limitations, we could achieve this on an ongoing basis. Also, non-availability of any modality of management or investigation is never a limitation. Here is an example of a genetic study which was done in one of our patients with Cushing syndrome in liaising with a very scholarly individual from France, and that brought such a depth of learning to a hereditary form of Cushing. And once this mind's eye was open, so many more Cushing along these lines we could investigate and change their management so very effectively. Also, that brought in a fundamental question and a fundamental system to say that one had to be self-reliant. One had to produce the systems in the department so that department never lacked any depth of learning and any depth of patient care. And producing our own hormone assay laboratory was one such example which exists from 1989, and every time the type of methodology and the menu has been ever increasing to meet with increasing demands of learning and patient care. And finances to achieve these means is never ever a limitation. There are a huge number of people who believe in the cerebral energy which exudes in department like ours and in institution like ours, who are forever willing to strengthen your hands and help you out to produce that added another dimension of whatever facet that you want to achieve in your laboratory and in your patient care, which totally changes the training program as well. And that is one thing which we have been constantly able to achieve because of the sheer help that we had garnered from multiple charitable organizations. It is always a teamwork which makes any dream come true. And I was so to have this bright people, the team members, not only the postgraduates, the support staff, and including our helping hands in our department who always resonated with our principles, with our ethos, and worked hand in hand with us. And that produced the desired results. And always adding these multi-speciality clinics. Here is the example of our neuroendocrinology management group. Here is the example of our adrenal endocrinology management group, and such multiple multidisciplinary interdisciplinary meetings which we used to hold with various subspecialties, which brought together truly added and enjoyable dimension of learning. Research which follows all this great pieces of work and the great facets of work which come together is actually the culmination of what you've learned, and continued publications with help of people and bright colleagues like Tushar, Anurag, Virendra, and my several learned bright postgraduates meant that we could have more than 80% of our 200 publications which were international and which were truly a good piece of work which we are so proud of today. And as an added learning and certainly as an added facet of research, molecular endocrinology lab was set up in the department, and we've had help from 6 scholarly PhD students who have trained with us and continue to train with us. We learned how to use the beautifully kept databases right from Dr. Bhandarkar's time, which now sort of means more than 50 years of rich data that was collected, which became a foundation stone of our research. And that meant that we needed to ensure that we made our research visible, whether it was a platform presentation or whether it was publication. It needed to come in public domain to showcase the ability of Indian minds and Indian setups and the Indian institutions with their power, which needed to reach across the international shores as well. And here is the fruit of it: to be recognized by Endocrine Society of USA as the first department in the country for the Ambassador Exchange Program, where 2 weeks of training on both sides of the shores was achieved, and that was a joyful experience for all of us. And lastly, I would say fundamental to all this is the attitude that you built in your team members. And that came from this great spirit, the moving spirit of the department, who still continues to illuminate the department, who always worked for the cause and never for the self. Scotland. He came back and set up the department against all odds as a single man army and taught us how does one work for a cause rather than one's own glory. And that's what we've continued to amalgamate and imbibe on an ongoing basis to create an atmosphere of camaraderie and bonhomie. And that is something that we constantly seeked out to do so that people bonded. People not only worked to learn, people worked together as one extended family, which is beyond their homes, which was here in this institution as well. And that is a lifetime of joy which continues even today on over and above all the degrees that you accrue and all the positions that you accrue. A lifetime of joy which was bestowed upon me by this 99 postgraduates who chose to train with us, and this bright young mind still continue to illuminate my life. Thank you so very much, ladies and gentlemen, for your patient listening. And Professor Das, again, my heartfelt gratitude for this opportunity. Thank you very much.
I think, Nalini, I'm speechless to mention that it has been one of the best orations I've ever heard. And I want, in your name, it must be published. We have 19,000 people registered for this program, but it must hit lakhs and millions. Nalini, you have opened up newer vistas in front of the people. When teachers, medical teachers are taking a backseat, medical teaching is taking a backseat, so you have reiterated our faith on a job that we must do and the joy of doing it. All life with education. Patients are the best teachers. True teachers, our bright mind, the vice postgraduates whom you paid glowing tribute. The true teachers are the PGs. The passion for learning, the webinars, and also you told about the finance is never ever a barrier. You told about the teamwork, multi-speciality team, cutting across specialty today, and also the research, rightly said, transcends the learning and about the visibility of the department, which is a must. And lastly, attitude is everything. Thank you, Nalini. I have no audacity of compiling it or summarizing it, but today is the day you have made our day. I must declare from the rooftop, Nalini, that we are benefited beyond measure. And it's something which touches our heart and takes us to the pinnacles of wonder. Thank you very, very much on behalf of all of us. Thank you, Nalini. Thank you. My very close and dear friend, thank you very much for joining us. Dear friends, this is a session which is called the insulin therapy, the clinical advances, a clinical practical session, and we have the people whom Parvinder will introduce in his right royal manner, AK of the AK-47 fame, Banshi Saboo, the astute clinician, and my very dear close colleague, Professor Jothydev Kesavadev, the technological giant. Dear friends, Dr. Parvinder Singh is the professor and head, MD-DM, professor and head of the Department of Endocrinology at the Dayanand Medical College and Hospital, established the fast endocrinology and diabetes unit in the state of the Punjab, a great glory, creating awareness amongst the clinicians and, more important, created awareness among the patients. He has trained many physicians, many aspects, but intense training of 100 physicians in the diabetes management under various courses in IDF and PHFI. I present to you Dr. Parvinder Singh to take it forward. Parvinder, all is yours.
Gotcha. Thank you, Dr. Das, for the kind introduction. At the outset, I must congratulate organizer of NIS, especially Dr. A.K. Das, tireless, tireless, gentle, and goal-led among the physicians who are treating diabetes, right? For the wonderful virtual meeting we are having, and thank him for giving me opportunity to chair or moderate this session. And in this session, we have Diggest kind people here. Diggest, what is Diggest? The stalwarts of the, diabetes landscape are here. Dr. A.K. Das, right? Dr. A.K. Singh, who is, I will say, fantastic academician. And then you have Dr. Banshi Saboo, the showman of diabetes in India. I will put them. He is showman of diabetes, and he is the, he is very much innovative. Last time I had 2020 in RSTI. Fantastic job he is doing for the diabetes, for the awareness for diabetes. Then you have, he is a wizard in organizing. He is a wizard. And then we have another legendary Dr. Jothydev. I will say is master of technology in diabetes. For India, he is the master in technology. So we have three, stalwarts who will be delivering their lecture. And I just want everyone know them very well. It's customary to introduce the speaker, but as I said, Dr. A.K. Singh, I will put him as the astute academician. He has many meta-analyses. Career is fantastic, right from the MBBS days. He has many orations to his name, and I'll say he's fantastic guy as far as study, clinical research is concerned, meta-analysis is concerned. I just want him to write a book on statistics for the clinicians also. I request him to do that. And Dr. Banshi Saboo, you know him. All people know him. And if you don't know him, then I think you don't know diabetes. I will put it like that way. All right. So Jothydev, I'm not going into that, slides of the, introduction, because I know you very well. So I can offhand, I can give all the things. And Jothydev is having his clinic in Kerala, and now he has multiple clinics, I think so. And if you have multiple clinics, then you have to do telemedicine. He's the father of telemedicine in diabetes.
Yes, sir.
So starting from the south, I wish he should come in the north also, and can have few clinics here also in the hillside, and he can see the hillside of Himachal Pradesh and Kashmir, and can come to Punjab also. Most welcome. So with that introduction, I think I should start with the first lecture. The first lecture will be by Dr. A.K. Singh. He will be talking on new approaches to reduce hypoglycemia. That's the first lecture. And probably we can have one or two questions after this lecture. And then we have second by Dr. Banshi, strategy to reduce insulin prescribing errors. Then you have a third lecture, role of technological advances in meeting glycemic growth goals with insulin therapy. That's third lecture by Dr. Jothydev. So let's invite Dr. A.K. Singh for his first lecture. Dr. A.K. Singh.
In that wonderful introduction from the heart, A.K. Singh, who has been the editor of the Williams textbook of endocrinology, the Southeast Asian edition, who left diabetes cardiology DM to walk into endocrinology DM, as you rightly said, a academician of the excellent order. AK?
Okay.
Yeah, can you see my slides now?
Okay, sir.
Okay. Thank you very much. Thank you, Professor Ashok Das and Novo Nordisk team for this kind invitation. It's always a pleasure to be part of National Insulin Summit. And this is, really important in the context that 2021 would be celebrated at 100 years of insulin discovery. Thank you, Parvinder, my good friend, for kind introduction. Thank you, my co-panelist. Only request, as I informed beforehand, that I have another engagement. So I would be happy to take Q&A before Banshi and Jothydev comes up. So my job is to, tell you about insulin-treated diabetes and hypoglycemia concern. In fact, my presentation has got two parts. So the first part would be a typical clinician approach, which I always love. And the second part is on technology to improve, insulin-induced hypoglycemia. For that, I have got two leading interventional diabetologists, I always say, Dr. Banshi and Jothydev. So I would go a little detail in the clinical part, and then I will quickly touch upon, so that I am basically felicitating them to take you through the technological aspect of improving hypoglycemia outcome during insulin treatment. So let's look into what we are talking today. Insulin is the drug of choice in patients with type 1 diabetes, and also drug of choice in patients with type 2 diabetes who are insulinopenic. Period. Full stop. No discussion whatsoever. The debate lies when you have got a type 2 diabetes without insulinopenia, with insulin resistance, and their insulin may not be the first line drug. When we are talking about the guidelines across the world, ADA, ESD, ACE guidelines, IDF guidelines, we are thereby meaning that we are talking about type 2 diabetic patients, those who are not insulinopenic. So in this platform, I would like to remind everyone listening here, sometimes you might be feeling that, why we sometimes discuss insulin and other time we discuss, SGLT2 versus GLP1, because of the fact that there is no debate about use of insulin anywhere, right? So that's, if diabetes is a deficiency of insulin, you treat it with insulin, full stop. The question is, when you don't have insulinopenia and then you have got a diabetes, and that's where the other, anti-diabetic drug comes into the picture. So the entire, discussion today focus on when you are treating diabetes with insulin, be it insulinopenic type 2 diabetes, or of course it's type 1 diabetes where you don't discuss anything other than insulin. What are the limiting factors? Well, so as you all know, the insulin has got two important limiting factors, and number one, and perhaps integral limiting factor, is hypoglycemia. But don't blame it with the insulin per se. Insulin is the job is to lower blood glucose. It's a job of, a clinician who is treating, and it is also the job of patient who is being treated, that they should be aware about that we are not, when you are taking medications to lower down your blood glucose, there is a, always a possibility that you might go, beyond your threshold and land up in a hypoglycemia. Now, over the time, we are trying to recognize these complications and trying to minimize hypoglycemia induced by insulin per se. Now, because of this hypoglycemia factor, this is the biggest hindrance for every clinician as well as the patient. Patient also have got a, fear of injections, so that's injection phobia. That's a different issue which has been absolutely been taken out by modern pens, which doesn't bite you more than a mosquito. So I don't think the prick is a big issue nowadays, but then hypoglycemia does remain the concern. And as you can see in this slide, I'm not going to read, all those cartoons are in front of you. And because of this hypoglycemia, everyone is fearing to take insulin. Even physicians are having those limitations and not prescribing insulin. Not only these are the fears, but we do have data which suggests that hypoglycemia at a time, not always, can be associated with adverse, cardiovascular events leading to increase in mortality. As you can see in upper right corner, a core data, although this hinted that hypoglycemia leads to increase in mortality, this wasn't a causal association, right? So although we always suggest that hypoglycemia leading to increase in death, it has never been proven. You can make association, not the causality. That's a different story. However, we blame hypoglycemia induced sudden cardiac change, and if you are having established cardiovascular disease, that might end up in you a kind of change in your heart rhythm leading to death, and that all accounting into increase in mortality. The third important part is the hypoglycemia, which is actually important, is the cost related to hypoglycemia. As you can see in lower slides, there are direct costs involved, there are indirect costs involved. So basically hypoglycemia is the rate limiting factor, I would say, not a limiting factor for the treatment of diabetes with the insulin therapy. Now, over the years, we are trying to improvise this hypoglycemia, and there are certain conditions which are often associated with hypoglycemia. As you can see, the most important remains the renal impairment. Always be careful when you are using insulin in patients with kidney disease. There are several other conditions. I don't know why pregnancy has been put into this list into. Yes, in pregnancy, the threshold for lower blood glucose or higher blood glucose are different compared to non-pregnant state, but pregnancy as such doesn't lead to increased risk of hypoglycemia. But all other conditions you cited here is of course associated with hypoglycemia. Remind you, when you are treating patients with diabetes with kidney disease, always think about hypoglycemia, especially in patients with chronic kidney disease. Now, so how to reduce this problem with insulin? As you can see, several attempts have been done in past, 2 decades or so, especially in the insulin field. We are trying to use a newer approach, either to improve a pharmacological treatment, trying to have a good, insulin molecule itself, which has got, less tendency to produce hypoglycemia. You can see the modern insulin analog has come up a lot and changed the entire landscape of what we used to treat with the earlier NPH insulin. Although there is no difference in glucose control, and I keep on reminding that we have improvised insulin not for the great glucose control, because at the end of the day, all lowers blood glucose similarly, but we have improvised basically on lowering the hypoglycemia outcome. And I will quickly take you through those trials and study how the modern insulin had changed this hypoglycemia outcome over the time. Second part is the technological advancement, which I will not go into detail, because as I said, my next speaker is going to go into detail on technological advancement to minimize hypoglycemia. So ladies and gentlemen, over 100 years, you can see in front of you what happened in the insulin space, and you have seen this slide. I'm not going to detail. Every time I can tell you, the scientist, clinical researcher is trying to improvise the insulin formulation basically to minimize hypoglycemia. So that's, one space where people are constantly looking into improvising the insulin biological molecule. That's the greatest thing since the insulin discovery way back in 1921. Now you can see the story, and these research has led into translating into the clinical outcome change. If you see this slide, you have got 3 outcome data in front of you. When we came out with glargine U100 and detamir insulin from the NPH space, again I would say that there was no difference in the glucose control between glargine and detamir versus NPH, but the hypoglycemia outcome improvised significantly. As you can see in front of you, the nocturnal hypoglycemia with 2 newer insulin, for example glargine and detamir, reduced by 29% to 65%. In fact, detamir even causes less hypoglycemia compared to the glargine. There's nothing denying that. The only issue which happened with the detamir that you need to have a little higher dose of detamir to have a similar glucose control when you compare it with the glargine. However, because of the biological nature of detamir insulin, that albumin bind insulin, you had a much lesser nocturnal hypoglycemia with detamir compared to NPH. Even in detamir glargine trial, detamir showed lesser hypoglycemia compared to glargine. But as I said, the only issue which happened with the detamir with the requirement of insulin dose were somehow 20 to 30% higher than the glargine to have a similar glucose control. Nevertheless, both the insulin was quite better in improvising the hypoglycemia outcome. The middle slide is with a newer concentrated glargine insulin formulation, which is glargine U300, and they were compared in head-to-head trial in number of trials, and again you can see there was significant improvement in the nocturnal hypoglycemia outcome. So basically, these newer modern insulin analogs are getting improvised in reducing hypoglycemia outcome, in particular the nocturnal hypoglycemia outcome. And on your right hand side you can see when the trial was conducted with digludec versus glargine U100 in different begin program, again you can see there was a significant 53% reduction in the nocturnal hypoglycemia with digludec compared with glargine U100. So basically this slide gives you a simple hint that the modern insulin analog has really changed the landscape of reducing hypoglycemia outcome. And this is not limited to the basal insulin alone. Let's look into the premix formulation or premix analogs insulin. Also we will look into the faster acting insulin. Now you have got this slide in front of you which gives you the data of premix analog versus a conventional premix. So when you are looking into the bias 30, which is Novomix versus human mixed start, you can see again hypoglycemia outcome. This is 55% reduction in major hypoglycemia reduction with premix analog insulin compared to conventional premix. Even if you compare the premix formulation to the premix analog mixture like IDEG ASP compared to bias, again there was a significant 84% reduction in severe hypoglycemia. These are not a small outcomes. Any hypoglycemia outcome is welcome, but if insulin has got potential to reduce hypoglycemia by 50%, I mean that's there's no match to talk about these insulin. Now you see the difference. The premix analog had 55% less hypoglycemia. The premix co-formulation IDEG ASP had even 84% better than the premix analog. That's amazing innovations over the time with these modern insulin. And again, as I said, it was not limited to the basal insulin, not to the premix. Let's look into the faster acting insulin as well. So the newer insulin is part when you compare with either a conventional regular insulin or even a faster acting insulin as part. Slides in front of you on your left hand side is comparing the fastest acting insulin, faster acting insulin as part to the regular insulin or ultra fast acting insulin, FIASP versus the faster acting insulin as part. Again, you can see there is a significant reduction in hypoglycemia outcome with even the ultra shorter acting insulin compared with either conventional regular insulin or even the faster acting insulin. So one thing is pretty clear. The scientists are doing a fantastic job in making newer insulin which has got a significant less potential of causing hypoglycemia. Full stop, and there is no argument, debate about this part. You can argue that whether these are relative risk of hypoglycemia versus absolute risk of reduction in hypoglycemia. As a scientist, you can keep on debating on those benefits. But as I said, even if the relative risk reduction is more than 50%, this gives you a meaningful clinical difference in outcome. And even if you do it statistically, it is a quite significant. If the reduction is more than 50%, this gives you a p-value of 0.05. This suggests that if the insulin has got a potential to reduce hypoglycemia by 50%, this is of course a superior outcome, and you don't need to look into the relative risk reduction in hypoglycemia. Even the formulations like, Libre, of course, Jultofi had changed the landscape of treating diabetes by adding a GLP-1 receptor agonist with a basal insulin. And if you see the hypoglycemia outcome, you can see in the extreme lower right-hand side, this green color versus gray color, and you can make out there is a significant reduction in confirmed hypoglycemia compared to, when you are comparing Libre to basal bolus regime comprising of basal insulin glargine U100 with insulin spot. So over the time, whatever kind of innovations have been done, it was basically trying to improvise reducing hypoglycemia outcome. So basically that was the clinical part, and now I'm basically inviting my next speaker to actually get ready with this technological advancement. We are going like tooth and nail to improvise hypoglycemia with the technology. It's a modern the smart days of technology, and it's not only on your hand with your gadgets. Now it's also getting translated into improving outcome while you are treating your patients. So we have got innovative monitoring, we have got telemetry systems, and I'm not going to detail because, as I said, my two speakers next to me will speak on what is SMBG versus continuous glucose monitoring. These people can debate on those issues, whether you are monitoring glucose through a glucometer or you are doing through, of course, a real-time constant glucose profile would give you a much better, understanding of how to titrate the dose of insulin compared to someone who is, pricking with a glucometer and doing on a random blood glucose testing. I don't think there is debate about that CGM is technically a better tools than the SMBG, but then it has to be debated in the context of patient's comfort, cost, etc., etc. The next speaker will go into detail. Again, the data suggests that CGM gives you a much better outcome to improvise hypoglycemia outcome. I will not, go into detail. The glucose telemetry system further improvises your hypoglycemia outcome because directly transmitted into a centralized monitoring system where nurse can look into the glycemic excursion, and you can be immediately managed to minimize hypoglycemia. And you can see the data in front of you clearly suggesting that the glucose telemetry system is a smart way of reducing hypoglycemia outcome in an inpatient hospital setting. There are certain things which is also in the pipeline. This is a future perspective of reducing hypoglycemia. We have got a dual hormone closed loop system. You can see you have got insulin pen where you have got insulin loaded with glucagon. So when your sugar is high, insulin takes care of, and sugar is low, glucagon takes care of. That's very interesting closed loop system. Then you have got a pen connected device, NovoPen 6. You can see, as I said, these are the modern technological advancement basically to improvise hypoglycemia outcomes. And then we have got machine learning and a smart insulin. I'm sure the next speaker is going to take you into detail of these parts. I will finish my presentation by simply suggesting that in last 100 years of insulin discovery, we have come out, from dog pancreatic extract. You remember Leonard Thompson's and the Benting and Bell's discovery. We have come up a lot, and we are thankful to those researchers who come up with these innovations, to take care of our patients, to give them the maximum comfort with, with the best outcome possible to reduce hypoglycemia with the modern insulin which we have. Thank you very much for your patience list.
Thank you, Parvinder. With your permission, we can take two questions for AK now because he has to leave. AK, I have one question to ask you, which is regarding the numbers of hypoglycemia. What numbers you stick to? Number two is regarding, as you rightly placed, that the modern insulins like Ideglid or Ijodec are totally free, and type 2 diabetes has hypoglycemia as a fear, and that is a limiting factor. Would you also advise your perspective on the two things that you have written about? One is not related to this topic directly, the hydroxychloroquine-induced hypoglycemia in a diabetic and keto diet-induced hypoglycemic. And for all the answers, you have 1 minute.
All right. Well, so SCQ induced hypoglycemia, per se is not related to the drug monotherapy alone, but when SCQ is used with other anti-diabetic drug. And as with any anti-diabetic drug, you have to be careful when you're using a multiple drug. The keto is, induced diet, of course, to me, frankly, sir, I feel that, all this keto, everything is bad to me. Right, it's getting out. It should go. It came up with a lot of noise, but it will also go with a lot of noise. It was bound to happen. Now, when it comes to a hypoglycemia outcome, your first question was, and I was always trying to make people understand. In any outcome trials, if the difference in relative risk of hypoglycemia is more than 50%. For a statistician, even a 15%, 15% outcome difference is considered as a clinically meaningful difference in the statistical parlance. Now, when you have got a modern insulin which can reduce hypoglycemia to somewhere from 50 to 85%, means then there is no debate on looking into the absolute risk reduction. Remember in the earlier term, we can see the people debating what is the difference in the absolute risk of hypoglycemia between insulin degludec and glargine EU100. Well, so it is a minuscule, but when it translates into a relative risk of more than 50%, it is again highly clinically meaningful. So you can keep on debating between relative risk versus the absolute risk. The fact remains is any ounce of hypoglycemia reduction is always useful for my patient.
Thank you for brilliant answer. Parvinder ji, you can ask one question or you can take up anything else.
I think Dr. AK is in a hurry to go. We can move on to the next speaker. And
thank you very much.
Give him a big hand. Very nice lecture. As usual, Dr. AK Singh has given a very sound foundation to the further speakers who will be developing on the technology also and errors in prescribing insulin also. So now I invite the second speaker, please, Dr. Banshi. Thank you.
Thank you. First of all, thanks to Dr. A.K. Das, sir, for giving me an opportunity to talk on a very important topic. So thanks to NIS and organizing team of NIS. Thanks, Dr. Parvinder, for very kind words for me. What I'm going to talk in next 15 minutes, a strategy to reduce insulin prescribing errors. This is something in between topic is being given to me between Dr. A.K. Singh, who is a legendary figure in India as far as to talk on diabetes, and then we have a technology guy from India again who is going to talk about the different technology. But this is very important topic, and when I had gone through this topic, I understood that hearing how important it to reduce the insulin prescribing errors. Even at the time of prescription itself, we are doing so much and so many errors which can lead to so many problems. So my first slide, my disclaimer itself is that insulin for the patient can be associated with many errors while prescribing, dispensing, and injecting. But I'll be talking only about the prescribing errors, which are very, very important. Other medication errors are also there along with that insulin, but they are beyond the scope of my discussion. I'll be talking about insulin prescribing preventable disorders. So the why we should discuss about insulin prescribing errors, it is a narrow therapeutic window. We know that even by just increasing 2 units or 4 units, it can lead to hypoglycemia. What the previous speaker was talking about the hypoglycemia. So simple prescription error can lead to also a lot of hypoglycemia. We are discussing about different type of molecules, but even a molecule which can be given in a wrong dose can lead to more problem. The variety of insulin products which are available, including concentrated and biosimilar insulin, which are there in India, there are 100 IU insulin, there are 40 IU insulin, and they are given by the different insulin syringes, which can also lead to a problem. There are similar sounding brand names, which can be also the reason for a prescriber to write something different he can write. The varied terminology used to describe them and increase potential for harm when prescribed or administered erroneously. How common is a prescription error? This is very interesting paper, which is a National Diabetes Inpatient Audit, NADIA, in 2019, which was British National Diabetes Inpatient Audit in 2019, reported that 2/5 of those treated with insulin, I mean 37% of type 1 and 40% of type 2 diabetes, they experienced an insulin error while they were in hospital. And this is something really from 2010 to 2019. This data and audit is been done, and they had seen even in 2010 to 2019 there is a slight decrease is coming in last 10 years, but still the number of errors are still very high inside the hospital when the patient, whether it is type 1 or patient who is type 2, as far as insulin prescription is concerned. In India, there are at least 7 different companies. Again, John Matthew in 2005, he had published an article. At that point of time, there are 7 different companies who are making insulin. Availability of human and analog type, different formulation, regular, NPH, lenti, 30-70, 50-50, add to complexities in prescribing insulin. And this is not only by diabetologists, but even by the primary care physician and other non-physicians. Their prescriptions error, which we are seeing every day, are very, very high. The errors involved in timing of insulin doses and illegible handwriting, which is confusing between IU or U or 0, add to the prevalent confusion. For the sake of convenience, several doctors relate to regular insulin as they just try to say that regular insulin are normally clear insulin, but it is no more true, because now we have clear insulin like Glargine, which is a longer acting insulin, which is also a long acting insulin, and it's clear also. And then we have a short acting analogs as well as the regular insulin, all of them are clear insulin. Further, patients on Aspart or Lispro with Glargine combination will be using 2 different type of clear insulin, because he has to take one longer acting and one short acting insulin. Both of them are clear. So then again, it can lead to mistaken as far as prescription is concerned and may lead to a lot of hypoglycemia. The prescription errors are insulin either name is not written, name is incorrect, dose is unclear, unit is abbreviated to U, and that is written unclearly. Insulin prescriptions are not signed, insulin given but not recorded and signed in chart. So in hospital, they may sign in the chart, but it is actually given or not given. Device to use not mentioned, and insulin prescribed at the wrong time also. These are some of the example which I want to give you here. Here you can see on the left side, there is a regular insulin subcutaneous before breakfast, before lunch, and before dinner. You can see here they had put the U. It is 4U, 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 but it can be confused as a 44, 44, 44. The other side here you can see insulin R 100. It is given subcutaneous straight, 4 hourly subcu straight. This is what how much dosage is to be given, not clearly written, and how it is written. We don't know. It is 100 IU per ml, which they want to have, and which needle or syringe they have to give, it is not been prescribed also clearly. Here the insulin soluble, which is 8 unit TDS subcutaneous frequencies like this, 8 units 3 times soluble insulin with soluble insulin which they want to write. Difficult to understand sometimes the instruction also. Here it is written 6 units TID according to blood sugar, but we don't know what exactly they want to write it. And this is very commonly written like Humalog 4U, 2U, 6U, as you are saying that this U looks like it's 44 units. So these are the some of the common prescription error which we are seeing in our country also. So preventing prescribing errors, there are strategies to improve insulin prescribing quality are needed to reduce insulin error inside the hospital. There is a wide variation in the use of recommended strategy to help improve insulin prescribing quality, including mandatory education of healthcare staff, self-administration and self-management policies, and prescriber support at the point of care transfer. The use of electronic prescribing system is slowly increasing, but there are significant difference in the functionality of system to optimize insulin prescribing safely. And now we know in India also in hospital we have an electronic prescribing system which had come. The presence of a specialist diabetes pharmacist which is not available in our country, but we have the educator and the doctor himself or the resident doctor who are writing, but we should educate them properly. The increased use of insulin prescribing safely strategy they should use in the hospital. What are the intervention to improve insulin prescribing? One, that strategy to prevent prescription error. It's a provider education, provider decision support, changing the team, adopting a better policy, restrictive change of the use of insulin types. I mean, they don't want to use the multiple different types of insulin inside the hospital. This is again a paper from UK hospital because they found that a lot of prescriptions error were there. Even from 2010 to 2019 they could reduce, but not significantly. And regular audit, which is very, very important, which is completely lacking in our country. And there is an insulin prescription charts which were given to resident doctors and diabetes insulin prescriber pharmacists or nurse to reduce the errors for prescription. Provider education support is mandatory induction training for prescribers, mandatory periodic booster education, organizing lunchtime teaching modules regularly because that's the time when they get off time, and during that time teaching modules can be done. Dedicated projects like making insulin treatment safer. This is a MITS project which is a very important project just to educate the pharmacist and educate the educator for insulin prescription. Dedicated celebration of insulin safety days, insulin specific e-learning package which can be browsed at any given point of time. This is what making insulin treatment safer. This making insulin treatment safer, a novel approach to workplace assessment in foundation education. The provider decision support, local hypoglycemia guideline and hyperglycemia guideline which should be taught. Corrective or correctional dose algorithm should be very clear to the doctors or a resident doctors or the diabetes nurse, that what should be the correctional dose when the pre-meal sugar are high. The dedicated prescribing chart for diabetic ketoacidosis and the hyperosmolar hyperglycemic state. Use of pocket size guideline or cards which can be given inside the hospital or even in the OPD where they are prescribing. Insulin discharge checklist, insulin device on discharge sticker, insulin passport given to each patient, so they know that what exactly the dose is being prescribed to them. Use of standardized electronic records which can be accessed from anywhere. So even if you have a prescription which has been written to the patient, even after a few days, when patient have a confusion, you know that there is an electronic records on which it is written properly. The insulin discharge checklist is very important. Like this patient who is been given an insulin passport, and the passport had shown that very clearly that he is on Humalog, which is on a cartridge. So again, I have a diabetes, I'm taking Humalog cartridge, I'm taking XYZ insulin in this particular dose, and that is what a passport which is given to the patient, and an insulin discharge checklist which is being given from the hospital for nurses. There are multiple points which are written very clearly, and this discharge checklist is given to the patient. Strengthening the team. The journalist, pharmacist review of these prescribed insulin as a priority using prioritization software. Specialist diabetes nurse of whom some are independent prescriber, because in India we don't have that a diabetic nurse who is independently prescribing, but normally in our clinic we have either a diabetic nurse or a diabetic educator or a assistant doctor who may prescribe on behalf of a specialist, but again they need to be educated, because there are a lot of errors which we are seeing when it is prescribed from even a busy diabetic clinic, or somebody who is a senior diabetologist, because it is written by someone else who could be a diabetic nurse or who could be a diabetic educator. A pharmacy-led insulin self-administration assessment, identifying patient prescribed insulin at nursing handover. That's very important. When patient is buying from the pharmacy, again at the educator, it may be in UK, it could be a diabetic specialist nurse, or in India, it could be educator, again to explain them whatever the prescribed insulin which is given to them, it should be educated them properly. A 7-day clinical pharmacy service in patients with inpatient ward. In our hospital also we have an inpatient ward, but we have a dedicated a staff or an educator who can teach our patients who are on insulin. So the policy changes, the insulin prescribing by brand name only. This is very important. You cannot write just insulin regular, or just insulin short acting, or a soluble insulin, or just a insulin, because it has to be with the brand name. Different brand names come with the different devices, and they are coming in a different concentration. So that's the reason insulin prescription should be by brand name. Self-administration policy for use of biosimilar insulin, availability of hypo boxes on wards. So in hospital there should be a hypo, should be very clearly written about the what are the things which are available in these boxes. In emergency, if somebody develops hypoglycemia, they can be given immediately glucagon and the glucose tablet. A therapeutic substitution guideline if non-formulatory insulin device is not available. Dispensing alerts and special medicine bags for concentrated insulin. Those patients who are using 200 IU regular or 500 IU regular, there has to be a special alert should be given along with that bag. Insulin is stored in a patient locker instead of the ward freeze. This is also commonly seen in our country, because the commonly in a hospital, in a ward only, in that freeze only, the patient's insulin is put, and then it can create a lot of confusion between one patient to other patient also. Implementing restrictive changes, removal of insulin cartridge for use, default use of pre-filled pen unless cartridge is specified. Use of only one insulin time for correction dose to reduce mix-up and confusion. So this is for a correction only one different type of a short-acting insulin analog. If it is written, then that is to be clearly told and to be explained with the patient as well as to the diabetic nurse. Mandatory validation of high doses and limited number of insulin vial in every ward freeze for straight or fast dose, first dose. So this is also very important, the mandatory validation of high dose, like where it is written for you and somebody is confused and he is thinking it could be 44. So this type of, when there is a high dose, they should have a, again, validation should be there from the prescriber that this is the high dose which is written for that. There should be a regular audits and a feedback, monthly audits reported to what? Insulin related adverse incident report from reviewed and trends identified, monthly safety lesson learned meetings to review diabetes related incidents, weekly lunchtime meeting involving answering insulin query, wireless monitoring of blood glucose level provides alerts to acute inpatient diabetes team when blood glucose range are out of range. Insulin prescribing error reduces after adoption of insulin prescription form. You can see there is a significant difference once the patient is being given insulin prescription form, that and the hospital had adopted these insulin prescription form. The percentage of all insulin forms with an error before and after changes were made to insulin prescription form, and these are the data from UK National Diabetes inpatient audit, and which had shown significantly difference when the patient was given the insulin prescription form. And this is the one of the example of insulin prescription form which is given by Diabetes Canada. The Diabetes Canada, they have different type of insulin which is whatever is available, and the person has to, if it is using premix insulin, whether it's a homolog premix or a regular premix, everything is written here, and clearly accordingly the insulin prescription form is given to the pharmacist and to the user and from the providers very clearly. To summarize my talk, insulin prescribing errors are commonly seen but are preventable errors, and this is very important. In this paper which was published from UK from their NHS data, which had shown there is a significant prescribing errors in hospital as well as for outpatient, and the similar errors which we are seeing in our patients and in our clinic also, and many of our patients, they are erroneously taking insulin, which lead to hypoglycemia, as we are talking a lot of technological advances and a lot of newer insulin which are reducing significantly risk of hypoglycemia. But insulin prescribing error itself could be a very common reason and very preventable reason for hypoglycemia and even for hyperglycemia too. There are many strategies that could prevent harm with the use of insulin, could be addressed by simplifying and standardizing the many processes surrounding its use. It is important to provide staff with ongoing education about insulin products and methods of delivery. Insulin prescription error is neglected aspect of insulin therapy. This is very, very important, and I must thank Dr. A.K. Das to keep this type of topic for the physicians, that insulin prescription error itself is a neglected aspect of insulin therapy, and it's need more consideration and research in this regard from our country also. With this, I thank once again, thanks to NIS organizing team, including Dr. A.K. Das, and thanks Parvinder for giving me an opportunity. Thank you.
All is yours now.
You are live, sir.
Yeah.
Thank you very much. Most respected Ekeda sir, thank you so much for this opportunity. And thank you, Novel Arts, and very privileged to be along with Dr. Parvinder, Dr. A.K. Singh and Banshi in this highly privileged panel. So this is my duty, meeting glycemic goals with insulin therapy. And in the next 15 to 18 minutes, I will be discussing the role of technological advances. And I'll be discussing the advances in insulin delivery devices and also the advances in glucose sensing. And I promise all of you that I will be having at least 20 to 30% of something which is new for you, something new for you to learn. And can you identify, this is the first insulin pen. The first insulin pen was launched by Novo Nordisk. It was Novo at that time, and that was 1985. And that was the beginning of an era of insulin pen therapy. But if I ask you a question, which came first, insulin pumps or insulin pens? This is the answer. And this is the story of evolution of insulin delivery devices over the last 99 years, right from the beginning of the discovery of insulin. Insulin pens were launched by Novo in 1985. But years before, almost 20 years before the launch of insulin pen, that is Novo pen by Novo Nordisk, invention of insulin pumps were there, and that was in the year 1963 when pumps were launched. Of course, the commercialization came later. And I would start the discussion with the best-in-class durable device, because this has revolutionized the delivery of insulin. So believe me, as important as any new insulin formulation will be the delivery device of the same insulin. So NovoPen 4 has got an accuracy of delivery of insulin for more than 5 years per pen, with a low force to inject dose, easy to read dose scale, and easy dose adjustments. And this is the best in class disposable insulin pen. And that is a flex touch. With the, I believe that this is having the lowest dose force for injections and very convenient for the elderly population. So uniquely designed insulin pen with no push button extension and with the easy touch button, and the accuracy is ensured from 1 unit to 80 units per click. And what about the medications? All the newer insulin formulations, such as Rysodex, which is currently reduced by the cost by 30%, but the pen is still available at the same reduced cost. Degludec, the GLP-1, liraglutide, all of these newer phenomenal formulations are available with FlexTouch. The innovations with insulin pens doesn't stop there. It continues. And this is me featuring over there at the ATTD meeting 1 year ago. And it was there, this announcement came, Abbott and Novo Nordisk, Medtronic and Novo Nordisk, entering into the partnership to provide integrated digitalized solutions. So these are the era of smart insulin pens, digitalizing the insulin pens. And at the bottom, you will identify the Libre sensor over there. So obviously, when you start with the reader, then the same can be read in the Libre app in the mobile phone. So over to a couple more details of these two pens. And the red one is NovoPen Echo Plus, and this is NovoPen 6. And both these are the new gen smart insulin pens or the connected insulin pens. They are NFC enabled with 800 injection dose memory, and both are compatible with long-acting basal insulin and short-acting rapid-acting insulin. And Echo Plus allows for half a unit dosing, and it is meant for pediatric population. And what about the disposable pens? For the disposable pens to get connected, Novo has the solution, and that is a dialogue. And this is an add-on to, like a cap, this is an add-on to the pre-filled pen, and that is again both for long-acting and for rapid-acting newer insulins. And how will you define a connected insulin pen? The connected insulin pens are either NFC enabled or it can be Bluetooth enabled. It can connect to the continuous glucose sensors from Medtronic or from Abbott, or it can via NFC gets connected to the mobile phone apps such as MySugar or Accucheck SmartFix. And here in the picture you see it gets connected to the glucose Diascend mobile app / platform, and thereby there is sync of data between the two devices. And this is another smart insulin pen. This is an FDA cleared smart pen for insulin delivery, and it automatically captures mealtime doses and it keeps track of insulin on board. And why are these insulin pens, these connected pens, another breakthrough discovery? Is very simple. These are partly automating the dose of insulin delivery. These are partly automating the delivery of insulin with the help of mobile phone apps, with the help of sensors, and wirelessly connecting with each other. And recently, Medtronic has acquired InPen, and now InPen gets connected to the Guardian Connect sensor. And this is an overview of MySugar app. MySugar is the most popular diabetes app globally, currently used by more than 2 million subjects, available in more than 75 countries, including for a free download in India. And you can see that all the essential details are featured there. You can enter, or you can wirelessly connect to other devices. And you have the vital data, you have the insulin data, you can get connected to the CGM, to the insulin pump, to the connected glucose meters, and with a plethora of functionality. Moving on to the history of insulin pumps. The first insulin pump was launched from Korea, and that was in 1979, and that is the Suil Dana insulin pump. They are still very active in the market with the newer generation of insulin pumps. But if you look at the documentations, including some of the earlier publications from our side, it is a Minimed 502, which is the first commercialized insulin pump, and that was in 1983. And these are all examples of tethered insulin pumps. And now there is another model which is getting more popular, and these are the tubeless insulin pumps or the patch insulin pumps. They attach directly to the skin and doesn't require any plastic tubing. They require only a tiny tubing to deliver insulin, no long tubes. So there are no strings attached. And this one is getting launched in India in the second quarter of 2021. And that's going to be the first patch pump for India. And that is the Accucheck Solo Micro Pump with a modular design, a very, very small tube-free micro pump. And that also comes with a diabetes manager, and that is the Accucheck Aveva Solo with an integrated glucose meter. And this is integrated to have the bolus advisor. It programs and it directs for bolus, base cell changes. Everything is possible with this diabetes manager, apart from the communication from your mobile phone, from your smart mobile phone. And this is the evolutionary continuum on how the insulin pumps can be broadly classified. So the earlier days, we used to have only the standalone insulin pumps. In 2006 onwards, we used to have the sensor augmented insulin pumps. So these were the open loop systems, and then the hybrid closed loop systems. And the future is towards fully closing the loop, and these are the artificial pancreatic systems. And in India, the first artificial pancreas was launched 5 years ago, and that was 640G. 640G could almost completely eliminate hyperglycemia. 670G is globally the first gen artificial pancreas, and Medtronic hasn't launched 670G in India, maybe because of the cost of the device. And this is a device where the basal delivery is automated once in every 5 minutes during the night time, but during the daytime, we need to announce the meals and then manually bolus. So an artificial pancreas or a hybrid closed loop system will have an insulin pump, one of the modern day glucose sensors, fairly accurate, and then these will get connected with an algorithm. And these are the algorithms which are modified. So the Diamond algorithm is the one with the newer generation insulin pumps with Medtronic. There is one more hybrid closed loop system, and that is the Diabloop's automated insulin delivery system, which includes the Calido insulin pump, which gets connected to a Descom G6 continuous glucose monitoring system, one of the most accurate CGM systems currently available in the world. And what is the immediate future? In another 6 months' time, Medtronic will be launching this product globally, and that is 780G. And 780G will be having the modality for adjusting the basal insulin 24/7. And in addition, it will have auto correction dosing. So in other words, even the boluses will be getting gradually automated. So it will be adjusting the insulin delivery, and it will be correcting the highs and the lows 24/7 every 5 minutes. And this is the future. This is actually the future, but this is again a modified hybrid closed loop system, and it's not a completely closed loop system. A couple of words about the D-DATs. So you see two D-DATs over there, and this is Damiano on the left, and he is the father of a type 1 diabetes boy. And on the right, you have another D-DAT, and these D-DAT stands for those with children with type 1 diabetes, and they have dedicated their entire lives for innovations related to type 1 diabetes, artificial pancreas, re-engineering the existing devices, and so on. And this is Howard, and this is the CEO of Typepool, the founder of Typepool. And this is Beta Bionics. Beta Bionics is founded by Damiano for his son David with type 1 diabetes. And these are very specialized insulin pumps, the iLet, which requires minimal data. You need to only enter the body weight and nothing else. The rest is taken care of by the system. So you have two independent housing systems. One will hold insulin and the other will hold glucagon. And this is the 2015 innovation. And now we have the third gen iLet. And this is granted a breakthrough device designation by the FDA in 2019. And this automates the dosing assessments, and both for insulin and for glucagon once in every 5 minutes based on the Dexcom CGM data. And this is a phenomenal breakthrough discovery for any automated insulin delivery device for diabetes. So for those of you interested to read more about the review on evolution of insulin delivery devices over the past 99 years, from syringes to pumps to pens to do-it-yourself artificial pancreas, you may please kindly go through this review. And another very detailed review, especially for those doctors and patients who are willing to and desirous to go for the do-it-yourself artificial pancreas. And these are some of the open source algorithms. There are 3 different types of do-it-yourself artificial pancreas currently available, and there are a couple of patients even in India now currently using do-it-yourself. So what are they? If you look at any device for diabetes, you know that the insulin pumps are there in the global market for almost half a century. But for any new product, the clinical trials, the regulatory procedures, they are very, very complex and time consuming. And hence the patients are restless. They're waiting and waiting and waiting for completely closed loop systems. In 2013, they formed the We Are Not Waiting movement. And this resulted in the beginning of DIY artificial pancreas movement. And DIY APS users, they individually will be using the unauthorized algorithms. So I repeat, DIY is not approved by FDA, not approved by any country. It is not commercialized. So these are all created by the patient communities themselves. And with the help of re-engineering and reinventing the existing devices, the CGMs, the old insulin pumps, and getting connected with algorithms, and even some of the newer patch pumps. And this is again a dream come true. When the commercialized devices are capable of 70 to 75% time in range, some of the DIY artificial pancreatic systems are capable of even 90 to 95% time in range. And that is incredible achievement for any patient suffering from type 1 diabetes. So from now onwards, I will move on to some of the advances in glucose monitoring and sensing. And these are the connected glucose meters. Of course, the CGMs are there, the time in range need to be calculated, and that is one of the ADA recommendations currently. But for 95 to 99% of our patients who cannot afford CGMs, this is a solution where you can get connected to the respective mobile phone apps, create digital glucose diaries, the time in range data from the multiple glucose meter readings, and even some of them capable of remote glucose monitoring. And how are these continuous glucose monitoring devices divided? They're broadly divided into professional and personal. And the personal will be the one which is used by the patient. The RT CGMs are the real-time CGMs where the real-time numbers and graphical information is available all the time. And ISCGM stands for intermittently scanned continuous glucose monitoring devices. And this is a overview of the Guardian Connect Generation 3 sensor, which is available in India for more than 8 months now. And this is a very, very accurate device for real-time continuous glucose sensing. But the downside will be 2 or 3 calibrations per day. Freestyle Libre, I will be giving you an account of 5 Freestyle Libre models globally available, of which 2 are very popular in India. And this is the retrospective device with a white reader, which will be there in our office with the doctor's office. And this is a device which was launched 1 month ago, and that was on the 1st of November. And this is Freestyle Libre. Freestyle Libre will give you a glucose reading when you scan. And that is once in every minute. And also 8 hours of retrospective glucose data. But the attraction or the motivational factor here is a trend arrow, very similar to Guardian Connect. And this is an example of ISCGM or intermittently scanned CGM. Freestyle Libre 2 comes with a blue reader, not yet available in India. In addition to NFC, it has Bluetooth connectivity so that it can provide you with alarms for low and high glucose and whenever the reader is away from the sensor. And this is the third model, Libre Sense Glucose Sport Biosensor. And this has got a history very much closely connected to Novo Nordisk. And this is exclusively for athletes. And this is again a consumer product, but the difference is the user will receive streaming glucose data. There is no need to scan. And this is via the Bluetooth. And this results from a non-exclusive collaboration with Super Sapiens, an Atlanta-based company. The founder of Super Sapiens include Phil Sutherland, who is again the founder of Team Novo Nordisk. And this team is involved in training these athletes. And these are the young boys and girls who are racing with diabetes globally. And this is the last model, that is the Freestyle Libre 3, the fifth model, which I believe is the breakthrough model. And this doesn't require any scanning. There is no reader. It is only the app in the mobile phone. This is not the Libre Link app, but this is the Freestyle Libre 3 app in the mobile phone. And it provides you with a reading every 1 minute. And the sensor is 70% smaller compared to all the existing CGM sensors, and including those previous models from the same Freestyle Libre. And this is cleared as an iCGM, and iCGM stands for Integrated Continuous Glucose Monitoring Sensors. And Senseonics recently, that is the implantable sensor, they have announced a partnership with Ascensia, and this is for the global distribution of this implantable sensor, which will have a lifespan of 6 months. So the patients will require 2 sensors in 1 year. So this is my broad summary. Technological advances are revolutionizing diabetes therapy and even transforming the diabetes guidelines. Advances in technologies from syringes to pumps to pens to do it yourself. And this is to accomplish 100% time in range and 0% time in hypoglycemia. And connected insulin pens for once daily users or for multiple daily injection users will soon emerge as the user-friendly option for completely automating the injections. So thank you so much, Novo Nordisk and respected Ekeda sir, for this opportunity.
Thank you, Dr. Jothydev, for a nice overall view of the technology and and the management of diabetes. My question to Dr. Banshi. Dr. Banshi, there are 3 interfaces, as you have already said, from provider to the patient, from patient to the pharmacy, and in the home, you have a patient who has his own relatives around him who can, all can interfere with this or can guide the doses and the insulin also. So in our present setup, there is currently from India, there is hardly any study in this respect, whether what are the commonest errors, although we each have own experiences. Like many of my patients who come from Canada, they come with the U100 and take insulin with the here with the U40. So there are specific errors, the patient who are coming from abroad, from Canada, from USA. Then there are errors, but we have not computed all this data, all right, as far as Indian population concerned. I think we should have common errors which the Indian patient generally have. We should have one study on that account. Do you agree?
One paper which was published long back in 2005, John Matthew, which I had just shared with that.
Yes.
And I fully agree that we don't have the these real world data from our country. But if you see from this UK data which I had shown, the NHS hospital, how much prescription errors are there. They had tried to show from 2010 to 2019. So I mean, continuous auditing was done and that audit data is published. So since last 9 years, even with so much education, everything is now on an electronic form where the prescription error should become less and less. But still, you can see there is a significant number of errors which are there. So one side, we are talking of technological advancement to reduce the hypoglycemia. Other side, we are talking of newer advances in insulin therapy to reduce the hypoglycemia. But you can see at the level of prescription itself, we can make so much problem and so many mistakes which can lead to significant hypoglycemia, even it can lead to hospitalization also. I had shown some of the things which is written commonly in India, the writing error which is very commonly written, like 4U, which looks like a 44 units. And many times our nursing staff and the person who is providing or giving the injection, they give also, and we find that they have a significant hypoglycemia. So this is very common prescription error. I fully agree with you that we should have some real world data, but again in India to do the auditing itself is most difficult. And I mean the self-reporting will be much more difficult. So what I could find out that some of the handwritten prescription which we had just copied and tried to show to our audience that these are common prescription error, and I'm sure all physicians must be seeing these common prescription error in our day-to-day clinical practice.
I think, Parvinder, I cannot agree more with you. You rightly said, sometime back the government of Maharashtra introduced that the prescriptions must be in the capital letters. You might have seen that news. And
yes.
As you rightly pointed out, Parvinderji, we need a small compendium. I think, Banshi, you can do it. There is one by David Lee, one by the one you would just Dr. Matthews, which you now cited. And we have in the hospitals the audit committee. In the other thing, the audit has to come from by the leader in the particular area or whatever possible. But I absolutely feel that having newer insulins is one solution. Another solution is to bridge and put the gaps filled up from the prescription to dispensing to the preparation to nursing error. I mean, you must bring out. I think, Banshi, you said you are sandwiched between two legends. You are no less. Your Indian Cricket League, your RSJ presidency giving to us the type 1 diabetes, the new ideas, diabetes bites, diabetes research, and the multifarious activities you have done going to next year puts you at the pinnacles of wonder. Jyoti, I have one question with Parvinder's permission. I just want to ask you that, of course, I have also told you many times, Jyoti, that can I tell it here? I have requested Jyoti to run a course about technology. It will be a paid course, and he is contemplating about it. Will come shortly. I must ask you that what is the advances today for the non-invasive monitoring?
Yeah.
COVID did not see the light of the day or did not sustain the light of the day. Non-invasive monitoring, what are the advances?
Yeah, there are a couple of advances coming up with the tears and with the earlobes. And non-invasive technologies, they haven't succeeded. And that is the reason why still the success is only with the I showed you. It is the thinnest and the smallest sensor. So it is almost similar to a non-invasive device. And when I say non-invasive, when you're using a CGM, if there is no calibration, it is similar to non-invasive. And the application of the sensor is 100% painless, virtually painless procedure. So we are marching towards a future where already we are having painless and non-invasive technology for continuous glucose sensor.
That's great. Last and final question. What Nalini said, attitude is everything. What distinguishes Jothydev Kesavadev from me, say Ashok Das and others in becoming technology savvy? I think, Parvinder, is a question that he has to answer. What makes you different and unique to technology savvy, to the chief of Banshi's army of RSJ technology group? So what distinguishes you from others? Give us the secrets. This is the last question because time is up. But no, I seriously mean it. I mean, it is your, I mean, it is Sunita, or I mean, who drives you? What drives you for the technology?
Sir, probably it started from my childhood because I used to experiment every technology on myself, and all the new insulin pumps, sensors, everything I used to experiment on myself.
Fantastic.
And currently I have 2 sensors on my arms, and I am still doing some experiments. So my family support, my staff, and of course blessings from AK Das, from all my friends. Banshi Bhai is fully supporting me, And
you have really excelled and put India in the country's map. I think over to Parvinder to last comment and wind it up. We have less time. Parvinder, please.
I think we have nice discussion and nice lecture by the legends of topics in respectively. We had Dr. Banshi, Dr. Jothydev, and Dr. A.K. Singh, and of course Dr. Das here. I thank you all for such a nice discourses, and thank NIS and Team Novo Nordisk for giving us opportunity to present all these things. Thank you so much.
Thank you.
Thank you, sir. Thank you. Can we leave now?
Thank you. Thank you. Dear friends, we are in for a very exciting, fun-packed session where there will be no white flags, but two giants will be introduced by the chairpersons whom I'll bring into foray. We have with us Dr. Alok Kanungo, Chief Consultant Diabetologist and Physician at the KIDS Kanungo Institute of Diabetes Specialties, Bhubaneswar, internationally famous for this IDF Fellowship Program of the Sweden, Karolinska Fellowship, and Chairman of the Ethics Committee of the Niger, and member of the Consultative Committee of the WHO on Diabetes. And I have very, my dear friend, Dr. G. Vijay Kumar, who is absolutely fabulous. Consultant diabetologist at the Apollo Specialty Hospital, Diabetes Medicare Center in Chennai. He has been the organizing secretary for the World Congress on Diabetes in 2015 in Diabetes India, Chennai. Executive Committee member of the RSSDI, Diabetes India, and the API of the South India. He is the Blue Ring awardee of the president of the IDF. He is the author and the organizer of the 3D conference on diabetes every year in Chennai, a hallmark event in the country. Over to the chairpersons to please tell the rules of the game and take it forward. Thank you very much. It's a very interesting session with two giants who will do and bring out the curse. The cream de la cream of the topic that we're discussing.
Thank you, Professor Das. You are a brilliant organizer, academician, and you have tremendous contribution to the field of diabetology in India and abroad, and you are known for your original work. It is a great thing that you are organizing National Insulin Summit, where you are able to bring all the best brains of the world to one platform. And I have the pleasure to chair this session for one of the most interesting debate, that what is the choice of monitoring in insulin therapy? Is it SMBG or it is CGMS? And for both the debates, there are two giants are there. And I have to introduce Professor Sujoy Ghosh, who is in the Institute of Postgraduate Medicine, Education and Research and SSKM Hospital at Calcutta. And he is a brilliant speaker, excellent physician, clinician, endocrinologist, and the most important thing is Sujoy is deep into research, clinical research. And the debate will be really interesting, and let us watch Dr. Sujoy Ghosh.
Before this, I will introduce Dr. Rajiv Koil as well, so that there will be continuity in that. Rajiv, my good friend, a dynamic guy from Mumbai. He is a consultant diabetologist at Dr. Kovil's Diabetes Care Center, and with more than 26 years of experience in managing diabetes and improving their quality of life. He is also the founder member of the United Diabetes Forum. All of us know that it's a iconic program. Every year we look forward to attend and learn something from that. It's a very innovative program. They always create something new always, and he is also associated with several famous hospitals in Mumbai. That is Nanavati, SL Raheja, and BSCS Hospital, as well as a consultant diabetes specialist in these hospitals. Of course, he is also known as an author for several publications in the field of diabetes, both national and international journals, and as well as delivered several lectures both at national and international levels. And he's also interested in patient education programs, and he also writes books and articles on patient education. Dr. Rajiv and Dr. Sujay are really looking forward to a debate, and I'm sure the delegates are going to enrich themselves with your, knowledge sharing capacity.
Vijay and Alok, each one of them have 12 minutes to put forth. Then at the end, they have 3 minutes each for the rebuttal. So you have to keep the timing.
Yes.
So, please, start.
Good afternoon, respected seniors, my chairpersons, and of course, Professor Das, without whom no can be complete. And of course, a very good afternoon to my opponent, Dr. Rajiv Kotu, for whom I have great respect. So the topic that we are going to debate on, I don't know whether there's actually any debate because I think both are complementary to each other, is about the choice of monitoring with insulin therapy, whether you choose SMBG or CGM. Now, if you look at the topic carefully, you're talking about people who are on insulin therapy. What does that mean? You would have to talk about patients with type 2 diabetes, gestational diabetes, type 1 diabetes. So you just can't pick and choose only type 1 patients because most of our patients would be type 2 diabetes patients and some would be gestational diabetes patients and only very few will be type 1 patients. And when you're talking about insulin therapy, you've got to think of all kinds of insulin therapy. You got to think of people who are on premixed, who are on co-formulations, those who are on basal, basal bolus, basal plus, and of course insulin pumps, including those on closed loop system. So if you're going to look at monitoring, you've got to think of everybody, not just think of people who are on, say, closed loop basal bolus. So no cherry picking, please. We've got to actually look at the entire group of patients of diabetes who are on insulin therapy. So the applicability should be to all and not to small subsets. So when we talk about SMBG, we are all very conversant with it. It's easy to use, and almost every guideline on earth recommend SMBG ahead of CGM. The CGM recommendations are coming in. Of course, we are looking forward to this great new tool, but still, gold standard still remains SMBG. It's simple technique. You can teach the patient very easily, can do it at home, anywhere at work, travel, during exercise, and it provides you accurate, immediate results. There's a real-time, immediate feedback, and the results are displayed within seconds. And if you look at all the landmark trials that we talk about and management, they have all used SMBG. So the amount of evidence that you have for SMBG-based clinical trials is mammoth, and it's going to take a huge taking on behalf of CGM to even generate 1% of the amount of data that we have with all of these landmark trials and SMBG. And both the patients as well as the healthcare professionals, they are quite comfortable by now. Most people are quite educated, whether it's the healthcare professional or some of the at least aware patients, how to utilize SMBG to improve their lives, improve diabetes control, manage hypoglycemia, detect hypoglycemia, and adjust insulin doses. And in terms of the benefit on it, honestly, if I actually have to go on listing the number of studies where SMBGs have been used to show that there is benefit of glucose lowering and outcome benefits, I think it's going to be tomorrow morning. So I'm not going to waste my time in trying to do so. So whatever form of diabetes you look at, type 1, type 2, GDM, or in all of them, it's very well established that use of SMBG helps lowering of blood glucose, reaching targets, avoiding hypoglycemia, reducing glycemic variability, and improving quality of life, treatment satisfaction, and the feeling of well-being, decreasing anxiety, depression, and a positive well-being feeling. Now, whenever you're talking about CGM, you're talking about a lot of data, but do we really need so much of data? Because, even when a patient comes with the SMBG reading, how many of us are actually looking at all of the SMBG readings? Let us be honest about it. So are we actually talking about information overdrive? In terms of the recommendations for SMBGs, there have been various recommendations. People would say, people talk about pricking your fingers 3 times, 4 times a day. But actually, do we really do that? In real life, we actually utilize that facility in a more intelligent manner. You tend to use staggered, focused SMBG readings as and when required to try and help and adjust the dosage of the insulin. Similarly, the RSSDI recommendation also talks about not necessarily doing SMBG 7 times a day, but using it intelligently. So the utility of the SMBG data would be to able to detect hypoglycemia. So you're having symptoms or you're suspecting, do it now, find it out, treat it. Unlike CGM, where it's only the flash meters that's going to tell you whether you have a hypo right now. And you've got to remember that CGM is just like insulin. There are various different varieties. So let's not club all of the CGMs together. I'll come to that a little later. But with the SMBG data, you can adjust dose, diet, exercise, physical activity pattern, improve outcomes. And now we have apps for the SMBG as well, which can try and detect or store the data. For example, if you look at this particular My Sugar app, it will be able to give you and generate data which would give you a lot of the trends of variability, ups and downs, and possible trends of hypoglycemia as well. And if you look at SMBG data, it can even give you parameters like time in range, time above range, and time below range. I'm just asking you to have a relook at the DCCT data, which clearly tells us about the time in range that these individuals were. So the additional newer information that you're talking about in the SMBGs and the flash meters can actually be calculated and figured out from a well-done CGM machine itself. The glucometers are good, but what about the CGMs? The CGMs, the systems may differ from the SMBG systems because there might be a lag period, because in the CGM you're not actually checking what's happening in the blood glucose. You're looking at a very different compartment altogether. You're looking at interstitial values, which does not necessarily correlate with what your actual glucose values are. There are issues with accuracy and precision. Of course, things are getting better with technology, and you might actually be over-treating hyperglycemia or hypoglycemia. And all this concept about, the arrow telling you the trend of glucose values might actually be fallacious. And this particular study looks at and tells us that less than 2/3 of the displayed trends of blood glucose levels matched calculated trends measured 15 minutes later, and only about 10% of the displayed trends deviated 2 or more categories. In terms of real-time CGM in type 1 diabetes, there is some benefit, but if you look at no studies solely included pediatric patients that assess rates of hypoglycemia as the primary outcome. So even in type 1 diabetes, even if you look at meta-analysis, if you look at all of the parameters that you are trying to look at, there is limited evidence on the impact of hypoglycemia. There are some studies, of course, which try to suggest that in type 1 diabetes, there might be an impact of hypoglycemia. But in terms of type 2 diabetes, data is even more appalling, with some actually showing no benefit at all. And in individuals who are on oral agents, with or without insulin, there's no difference at all. And if you look at this Cochrane review in terms of what happens in gestational diabetes and pregnancy diabetes, you will find that there is no benefit as far as the Cochrane review tells us. If you look at the systemic review and meta-analysis of effectiveness of CGM on glucose control in diabetes in type 1, this meta-analysis also suggests that there's possibly no benefit in type 2 diabetes. There might be some benefit, but that is for retrospective CGM, not for retrospective CGM, but that for real-time CGM. So even within the CGM, you have different kinds of systems. Some might have some benefit, others definitely don't have any benefits. This is again another meta-analysis which shows that additional benefit in intermittent scanned CGM on time in hyperglycemic range, glycemic variability, hypoglycemia is unclear at this point of time. Future clinical trials are warranted to investigate the role of intermediate scanned CGM in patients with uncontrolled diabetes using insulin or other drugs. And like I said, there might be overestimation of hypoglycemia diagnosis by the real-time CGM machines that you're using, leading to incorrect management a lot of the times. And regarding the side effects, the less said, the better. At least about 10% of the individuals will develop contact dermatitis. And this is what the ADA 2021 talks about, that skin reactions either due to irritation or allergy should be assessed and addressed to aid in successful use of device. People who have been using continuous glucose monitors should have continued access across third-party payers. So unless and until someone is paying for it, this is probably not worth it. So affordability, accessibility, and accuracy are three problems which are clearly a problem with these. These are not readily available, expensive, can be used only for a limited period of time. You can't expect that the patient is going to pay and keep on, changing the CGM patch and be wearing it all the time. Whereas you can have a glucometer and you can use it as and when required. And most of the older machines, at least, need still SMPGs to be done for the calibration of the CGM machines, not all the newer ones. And cost, of course, as I've said. In terms of the standards, the glucometers are much more standardized now with time. But when you talk about the CGMs, the less said, the better. And even the MARD that has been used, it just looks at one aspect of the CGM. It does nothing about
Welcome on board. This is your captain.
VG. There's inaccuracy and lack of standardization. There are various types of CGM, so you can't pick and choose and say, this is the benefit of this and that's the benefit of that. Utility in type 2 diabetes, additional data with regards to outcome. Because, one of the things that people keep on talking about glycemic variability and the extra benefit that you might get, where is the data to show that these benefits translate into clinically meaningful benefits in terms of complications? That's very, very limited. We need much more data on that. Utility in type 1 diabetes, not all insulin regimes are you going to get, and not everybody is going to be on pumps and closed systems. Thank you very much.
For him, now I have to use very simple warfare to actually deal with him right now. So mine is choice of insulin therapy. What's the choice of monitoring with insulin therapy? And it's going to be CGMS. Can I have the next slide, please? So almost 4 decades back. So we all know that Sujoy is the Amitabh Bachchan in diabetes, and he spoke about affordability. इतना सारा data देता है, इतना experience है, तुम्हारे पास क्या है? And I'm the small younger brother to Sujoy, and I said मेरे पास माँ है और मेरे पास देवी माँ भी है, and that is what is extremely important. So next slide. So I'm going to explain to you. So this is what a typical plot that the SMBG guy takes to Sujoy's clinic with 4 SMBGs done, and then Sujoy changes this patient's insulin therapy based on this. Now this guy flies to Bombay to meet me, and what I do is I put a CGM, and let's see what the CGM says. So if you extrapolate this on a CGM, Sujoy missed all this. The patient was going into hypos, twice hypos, and hyperglycemia. And this variability is actually costing his quality of life. Now, that is extremely important. Apart from preventing complications, which I completely agree with Sujoy, that we need to prevent complications, quality of life is an extremely important thing. Next slide, please. So, what would you choose? All the delegates, 20,000 is what Dr. Das said. Photograph versus a videograph? Obviously, not a photograph. Next slide, please. Now, if you have a patient, we all give fitness for surgery using an ECG. It's the most useless investigation. Unless there's an acute problem, an acute MI or an acute rhythm problem, what does an ECG indicate? Nothing. But what will a TMT stress or probably a 24-hour ABPM indicate? Much, much better insight about the patient's cardiophysiology. Next slide, please. Similarly, when we check patient's blood pressure in the clinic, you get masked hypertension, you get white coat hypertension. Compare this to a 24-hour ABPM. You can get exactly what the blood pressure of the patient is at home and in his surroundings, which give him stress. Next slide, please. So I, coming from Mumbai, you can never book the judge the book by the cover. Similarly, you can never judge how good a movie is by just looking at the trailer. The trailer and movie can be completely different. So by just watching the trailer, you can never find out what the HbA1c is going to be. So HbA1c is that review one gets 1 star, 2 star, 5 stars, 3 stars on Sunday morning. So you need to watch the whole movie to get to a good HbA1c. Next slide. So now Sujay has just texted me, Rajiv, enough of all this, show me some real data. So first, Sujay, I'm going to show you data about glycemic variability. This is a study which came out at the at the Boston ADA 4 years back. It was the flat sugar study. Next slide. Now, we always know that for the last 100 years, we know insulin is one of the top 5 medical discoveries in this world. It changed a fatal disease like type 1 diabetes into something which was controllable. But even now, we don't know a strategy that can prevent micro and macrovascular complications. We are still scratching our mind to say what will prevent myocardial infarction in patients with diabetes. Is HbA1c a good surrogate marker of glycemic control? HbA1c does not reflect the frequency or severity of hypo and hyperglycemic events, and which may actually cause physiological changes that contribute to long-term risk. Next slide, please. So we are actually using a wrong surrogate marker. Now, today we have agents which are insulinotropic. We could actually reach euglycemia and compare it to patients who have glycemic variability and see if this whole essence of glycemic variability, whether there's any truth in it. So here is the study which compared, next slide, which compared GLP-1 therapy versus prandial insulin therapy on the background of metformin and basal insulin. And what did we compare? We looked at overall glycemic variability. We looked at circulating markers of cardiovascular disease. We looked at inflammatory markers and Holter monitored ECG abnormalities. We all know that we can have 2 patients with similar HbA1c. One can be having a lot of variability and one may not. Next slide, please. Now, the person who does not have variability doesn't make any difference. Next slide. So what we see is that here we are looking at the coefficient of variation between 2 types of therapy as determined by a mass CGM. Next slide, please. So here we have both the patients reaching the similar HbA1c of 7. Both the groups from 7.9 to 7.1 in 26 weeks. Next slide, please. And what we see is that the coefficient of variation is much, much lower in the GLP-1 versus basal insulin as compared to rapid-acting insulin versus basal insulin. So the rapid-acting insulin causes a lot of
situations as compared to GLP-1 plus basal insulin. Next slide, please. And what did we see? What did we see in this? That again, the MAGE, which is the mean amplitude of glycemic excursion, was much lower in the GLP-1 group. No severe hypoglycemia, weight gain was much lower. But importantly, levels of albuminuria, interleukin 6, high sensitive CRP and urinary isoproteins were much lower. Again, ECG abnormalities. The patients who had more glycemic variability had ECG abnormalities. Patients who had lesser glycemic variability, no ECG abnormalities. Next slide, please. So this is a proof of concept. We need to actually establish in a larger study, but you can have two groups of patients with glycemic variability and increased inflammatory markers, increased cardiovascular markers, and increased ECG abnormality as compared to a stable patient who could be in euglycemia, giving the latest insulinotropic drugs and not having glycemic variability. Next slide. Now let's look at further more data. This was the shock which Sujay is going through in his library. Sujay, you need to take a cup of coffee right now. Next slide, please. So old is gold. Now we always have athletes who compete for gold, silver, and then you also have the Diamond League, where all the top athletes come together. Unfortunately, when it comes to monitoring, CGMS has the gold, silver, and the diamond. Let's look at this data. Next slide, please. So gold study was published almost 3 years back, which looked at type 1 diabetes. Now, most importantly, Sujay spoke about type 1, type 2, secondary, gestational, but type 1 diabetes is the best medium to actually test a glycemic strategy. We don't have insulin resistance. So a strategy with the DCCT, headache, and the legacy effect and all that came from type 1 diabetes. The gold study was a 16-month randomized crossover trial, which looked at CGMS versus SMBG. So one group was on a real-time CGMS, the other group was on SMBG plus a mass CGM. It showed a reduction in HbA1c of 0.7%. But what data I'm looking at is called GOLD 3, which looked at whether CGMS affects on hypoglycemia. Means it gets HbA1c down, we all know. But whether it affects on hypoglycemia, and most importantly, whether it affects the quality of life of the patient, whether it improves the confidence in his day-to-day activity, whether he feels secure, a patient who's going into a party, a patient who's traveling with type 1 diabetes or a type 2 diabetes taking multiple doses of insulin. It clearly showed that CGM reduced the time in hypoglycemia, it improved the well-being of patients and improved hypoglycemia-related confidence. Next slide, please. Now we go on to something called a silver. Those patients who were in gold were extended to a silver study, which extended over 1 year. So the gold study was a randomized crossover study for 16 months. It showed HbA1c is better, hypoglycemia is better. We needed better long-term effects. And long-term effects, there was a significant HbA1c reduction of 0.35, along with the time spent in hypo and hyperglycemia, again showing benefits of CGM versus SMBG. Next slide, please. We look at the Diamond study. The Diamond study had 158 patients with type 1 diabetes. Users had 7.5 to 9.9% HbA1c, and there were 105 patients with CGM and 53 with using SMBG. And what it showed is that there was significant reduction in HbA1c with lesser duration of hypoglycemia. Again, 43 minutes versus 80 minutes in a day. Secondly, HbA1c, there was a 1.1% reduction and a 0.7% reduction between the active group versus the SMBG group. Next slide, please. Now, that's why the ACE came up with these guidelines that CGM should be considered in patients who have not reached their glycemic target after 3 months of initial anti-hyperglycemic therapy, and for those who require therapy that is associated with hypoglycemia. Use of personal CGM, that is real-time CGM, should be considered for those patients who are on intensive therapy and for those with hypo unawareness or those with recurrent hypoglycemia. Next slide, please. So this was from the world. So we published this data in 2013, which was at the Diabetes Therapeutic Society with Dr. V. Mohan as the author, that use of iPro in real-life setting in type 2 diabetes, again, it showed a 0.6% reduction in HbA1c when we used, this was a 3-day CGM 3 months apart. Next slide. We got this published in the JAPI around for 4 years back. Again, the use of retrospective CGM for optimizing management of type 2 diabetes in India. So SCGMS has started to replace SMBG, not today, but almost 5 to 7 years back. Next slide. And this was endorsed by the Indian guidelines, the Indian consensus guideline, which says the CGMS is mainly applicable for patients on CSI or MDI. Again, patients who have severe hypoglycemia. It reduces the risk of asymptomatic hypo. Again, to treat refractory hyperglycemia, patients who have a large glycemic excursions, we need to use a CGM. Next slide. So now we know that today in this pandemic, as I said, the pandemic is the mother of invention. It has become extremely important that today I am sitting in Mumbai, Sujoy is in Calcutta, Sir is in Pondicherry, GVK is in Chennai, Dr. Kanugo is in Bhubaneswar, and we are all connected. That's the digital. But imagine the workers who are taking care of COVID patients. We had 800 doctors who died in this pandemic. And that there may be another whole amount of people, the ayabais, the sisters who do SMBG. Now, suppose we could use a continuous glucose monitoring and could reduce the face-to-face interaction. We could do a world of good to our whole healthcare staff. Next slide, please. That's why this November 15, there was a publication in Diabetes Care, which looked at two groups of patients. Here you're looking at patients in the non-ICU hospital setting. These 50% of patients were given a real-time CGM, and they had a smartphone, and with the real-time CGM, their readings were actually sent to a central depot, as we have a central depot in the ICUs where all our vital care parameters are coming in. And here we now know that just hyperglycemia is an independent risk factor for morbidity and mortality in COVID patients. And here there's a study which came in during the pandemic, which tells us that glucose could be the fifth vital sign. Here you have a real-time CGM with the help of a smartphone directly via telemetry reaching the central depot. And here you have alarms put in. So the patient gets an interface with the doctor or the nurse only when the alarm goes in. And the time in range is better. So you get an alarm when the patient is in hyperglycemia, you get an alarm when the patient is hypoglycemia. So this is the future. We are looking at a future where real-time CGM is going to replace SMBG in hospital setting as well. And I had a conversation with Dr. Mohan where he's already using this. Next slide, please. So the conclusion is that real-time CGM can be successfully used in community-based practice. So the point of care which is used today in hospital setting needs to be given up. We have enough evidence to say that there is excellent calibration. The CGMs are standardized. We only need to teach our healthcare staff how to interpret. Next slide, please. It could be the true vital sign. So CGM assists in discovering unknown hyper and hyper, observation of glycemic variability, severe of hypo and hyper, highlight the impact of behavioral variances. CGMS enhances patient self-management, adherence, and confidence of diabetes. Most importantly, it also reduces diabetes distress. Now, diabetes distress is a complication, the fear of impending doom, and hypoglycemia is a rate-limiting step. If you can prevent hypo in our patients, we can make sure that the patient will live longer and be compliant. Next slide, please. So Sujoy now wants to learn. So my next trip is to Calcutta to have a workshop in his teaching hospital with his all his students. Thank you, Sujoy. Next slide, please. So SMBG, no way. It's always going to be CGMS for monitoring patients on insulin therapy. Thank you so much. I hand it back to the organizer. Thank you.
Yes. So the topic has been discussed both ways. Sujoy and Rajiv have presented their case, and we have to give them reasonable opportunity to defend themselves. And I give 3 minutes to Sujoy to counter Rajiv, and Rajiv will also have the opportunity 3 minutes to present his facts and counter latest allegations of Sujoy. But at the end, we'll conclude. Sujoy, please.
Thank you very much. I think Rajiv actually used up the 3 minutes of his rebuttal as well. Anyway, and I welcome you to Kolkata to come and teach me and my students. I'm always ready to learn. Right. If I go point by point, you quoted the flat sugar study, which is a very good study, in fact, but it only talks about the effects of variability. The topic that we are here dealing is about if an individual is on insulin itself, can the two modalities alter the variability? And does that variability alteration translate into clinical endpoint benefits of the patient? apart from small groups of patients of type 1 diabetes, in terms of variability, there is no data in predominantly most of the type 2 diabetes patients who are on insulin, because I'm a poor clinician who sees mostly type 2 diabetes. Maybe you see only type 1 diabetes. I do see some type 1 diabetes, but it's still a very small proportion of the entire population that I see. And secondly, even when we are talking about type 1 patients, you're talking about patients who are on basal bolus insulin only and or on insulin pumps, particularly closed loop systems. Now, if Novo has to close down business on its premixed insulins, the co-formulations, and even the basal insulin, maybe that small group of people who are going to be on that small group of basal bolus or closed pumps might have some benefit. And it is true that type 1 diabetes is the holy grail of insulin, and whether it's doing well or not. But I think for most of us who are seeing patients in the primary care level, secondary care level, and even most of our tertiary care levels will probably do as well as the others in terms of CGM versus SMBG. Of course, there's going to be a small subset of people where this might be useful. And you quoted the AACE guideline. And if you remember the wordings, it said it can be considered where in those with basal bolus or pumps who have not responded in the last 3 months, who have hypoglycemia unawareness, and where hypoglycemia is recurrent. Of course, I agree with that. And in terms of remote treatment of diabetes and remote glycemic control that you talked about, the paper that you suggested is a non-ICU setting, which clearly tells us that in someone where the patient is really sick, CGM is no longer a valid tool because of the lack of accuracy. And if you're talking about tools, even the My Sugar app with the SMBG readings will give you a similar kind of results in terms of outcomes of monitoring for patients. And I am not in favor of those doctors who have been treating patients with COVID like this, well from afar, not even going close to the patient. That physical contact and touch and the empathy that a physician needs to be there with the patient is something which can be dramatically, I have seen people coming and telling us, in the last 2 weeks, the junior doctor
in my practice,
yes, there is a meta-analysis on that.
Meta-analysis in real life, we've not seen more than 1%. In terms of, yes, you said non-ICU setting, yes, it's a powerful tool. It's an emerging tool. So you will initially be subjecting it to patients who are not in critical care. Once you know that, then it will go to the next level of setting. So we all know that IV insulin therapy also came into being in the Portland protocol, and we later on decided that deep sternal wounds could actually be a complication and we could treat it. So everything evolves. So CGM is a very powerful tool today. Standardization of CGM has also come through. Calibration, as you spoke about, there are some which require calibration. Most of them do not require calibration. The one which is most standardized is unfortunately not so freely available, which is the Descom G6, which fortunately, if it comes to India, it doesn't require calibration. It's very, very real time, standardized procedure. So over a long period of time, we are going to have much more implantable kind of CGMs, where you will have data coming in and data to almost the entire building. So you could have your data sent to everyone you want and they could interpret the data. So you spoke about 288 readings. More data is the next goal. So more the data, more the analysis, more the slicing, and more better for a patient. Most importantly, if you can give them better HbA1c, which it does, if you can reduce their hypoglycemia, which it does, both in type 1 and type 2, if you can reduce their hyperglycemic excursions, make them feel more secure. Most important thing is that, and reduce their diabetes distress. Cost is not a factor at all. And here we are here to tell all the people who are watching that adapt and adopt technology, because it's accessible and it's not expensive. It's very cheap. Thank you so much.
Thank you, Sujay and Rajiv. This is a very wonderful discussion. There are two aspects. One is social, second is economic, and third is science. SMBG is a point value. It gives at that point of time what is your glucose value. CGMS is a period value with specific pointers to rise and fall. Both are needed. Definitely both are needed. Both are good. Both are technologically developed. There are different things. SMBG has its own place, bedside place, instant decision, helping in hypoglycemic episodes, helping in hyperglycemic episodes, and giving a point value that where the patient is and how to go ahead. And it is a boon for patients themselves. At 2 a.m. in the night, if they have discomfort sweating, they can know that they are going into hypo or hyper. So SMBG cannot be ruled out, but CGMS is extremely helpful in managing diabetes. SMBG tells how is your blood glucose, whereas CGMS tells how is your diabetes, how is your metabolic control, how are you coping with the treatment. CGMS tells how good is your doctor, how good is he in understanding your glucose excursions and values. Is he taking clue from the CGMS and controlling your blood glucose or not? If time after time, if the CGS values do not improve, glycosylated hemoglobin do not improve, then possibly the therapeutic armamentarium that is used is at fault. So this brings doctors into cross check, and they must improve themselves to treat patients, because CGMS is looking at them and telling where is the fault and where is not the fault and which is the correct regimen. So dear friends, I think both are important. Sujay is very, very important. He is helping everybody with SMBG, and economically it is giving us till we get CGMS from Rajiv in a very affordable price, and then Sujay is the choice and Rajiv is our future.
I think BG has a choice. BG has a comment. BG, yes, come in. BG?
You're mute. You're on mute. You're on mute.
BG, please unmute.
Yeah. For the benefit of the delegates, I think what we need to do is some excellent. In fact, the debate has been excellent from both the people. I really thoroughly enjoyed and learned a lot from both of them. We have to, as for the benefit of the delegates, I would say that Dr. Sujay has said that complemented each other and the benefits of SMBG, because it is reachable to many, many people and is simple to use. And Rajiv has explained that we need to adopt the technology so that we can improve the quality of life. That's a very, very important statement. Like Sujay has given an important statement, and even Rajiv has given an important statement, quality of life, which is a very, very important factor that he has suggested, where we can prevent hyperglycemias and also the hypoglycemias, which are undetected otherwise. That's a very important statement. Even Rajiv, about 35 years ago when we started to practice, even SMBG was not acceptable by people. So Professor Das, you must be accepting. It was resistant. People were resistant to use SMBG. Today, after 25 years, you can see that everyone is accepting it. With the benefit of the technologies, especially the TIR, that is time in range and time in out of range, and probably in future it is going to be affordable. Definitely what Rajiv has said is also good. So I think we need to take it in a broad spectrum, and then there is usefulness of both of it, and it is complementary to each other, and that is what delegates should take it. Thank you. And sir, Professor Das sir, I'm really profound thanks to you for giving us this opportunity to join this.
Thank you, Sujay. Thank you, Alok. I think both of you. I think Rajiv, thank you very much. Sujay, I cannot thank you more. Sujay, you have brought out the points, and absolutely fabulous, and opened the newer vistas in front of the audience. And Rajiv, in your own style, inimitable style, you have established your points, which are valid. And dear friends, as rightly concluded, SMBG is the current, CGMS is the future. SMBG, I mean, that depends on, I will not draw any conclusion, but both are complementary, both are useful. When we decided the choice of the topic for the debate, our objective was to give to the audience the state of the art information, what should be done. And both of you, I thank you profusely for having brought out the creme de la creme of both and presented it for the audience. Thank you very, very much. Give a big hand to both the debaters. Sujay,
thank you, sir. Thank you so much. Thank
I
you, Sujay.
really enjoyed. Yeah, fabulous.
Thank you, sir. Thank you, everyone. Bye-bye.
Nice, beautiful. Thank you.
Thank you.